Welcome back, Rebel EM listeners, to another exciting episode of Rebel Crit. I'm your host, Frank Lodeserto, and I'm here with my co-host,
Dr. Eric Acker.
I call him our chief resident of our program, Internal Medicine. So Eric and I have dove into mechanical ventilation, and to go over where we've been, we've talked about the types of breaths. There's 3 types of breaths you can get on mechanical ventilation, the 2 ways those breaths can be delivered. And then we said in the second episode, you can make every mode of mechanical ventilation by just knowing the 3 types of breaths and the 2 ways those breaths are delivered. So if you haven't heard the first episode, second episode, I encourage you to go back and listen. Today, what are we talking about, Eric?
So we're going to go back and look at the respiratory system and what our goals are of oxygenation and ventilation. Those are the 2 main components of someone breathing in and breathing out. So this is what we're trying to accomplish with these vents.
Because we're doing it for them, aren't we, Eric? Now, we've taken basically control of their airway for whatever reason, but we now have the ultimate responsibility of oxygenation and ventilation of our patients. So this is a big responsibility that we've put on our hands now because our patient wasn't able to do it.
Yeah, exactly. They're no longer breathing for themselves. We're in charge of that. So we have to make sure that we get the machines queued up the way that we need it.
Yeah, and you said something too. What's our goal? Our goal here is to provide adequate oxygenation and ventilation. It's not perfect sometimes. It's not perfect ventilation. Sometimes we have this concept of permissive hypercapnia where we don't want to cause more harm to our patients, so we do allow the CO2. There's certain circumstances we can't, but in most cases, we allow the CO2 to be a little higher because we don't want to really beat the lungs up, cause more lung injury, which I think we're going to get into some of the lung injuries in our next episode. But adequate oxygenation, adequate ventilation doesn't have to be perfect, because when we try to get perfect oxygenation, perfect ventilation, we sometimes will cause some harm, which we'll talk about next time in the next episode.
Essentially, we're just trying to get them going with this ventilator while whatever main underlying cause is being treated and managed, and they can get better, get off the vent. What are some of these things we're going to do to get oxygenation up?
How I think about oxygenation is by simple diffusion. Things that go down the concentration gradient. So we have got to get oxygen from the atmosphere or from the ventilator to the alveoli to get into our bloodstream, to get to our end organs. How do we accomplish that? We'll make an exception to this, but we'll give the simple way first.
So FiO₂ is the primary one. You can crank FiO₂ up to 100 if you absolutely need it. Probably don't want to live there. And then it's PEEP.
PEEP. Yeah, that's a simple answer. We'll get a little bit more complicated in some of the exception to that, but it's by simple diffusion. So how does PEEP help with diffusion? Well, in your respiratory cycle, you spend 2/3 of the time, for the most part, unless you'd have some obstructive lung disease, but most of the time you spend in exhalation. So we don't want our alveoli to collapse. Now, we've taken over the patient's airway. Normally, we maintain our own PEEP. Our glottis closes. We maintain some volume of gas that exerts a pressure on our alveoli to maintain alveolar opening or PEEP intrinsically in our own body. But when we put a breathing tube in and basically violate the patient's glottic opening, now we are responsible for providing PEEP. And there's so many ways that people have speculated we can achieve ideal PEEP, and we may get to that episode. But basically, we have to provide some positive end expiratory pressure because we don't want those alveoli to collapse on us. We want to maintain alveolar opening. We want to maintain a good surface area so that by giving FiO₂, it is able to diffuse into our bloodstream and provide adequate oxygenation through simple diffusion. Does that make sense? Did I wrap that up?
That's essentially how we're taught in medical school.
There is one exception, and we'll get into a little more high-level ventilator discussion here. But the truth is that the mean airway pressure is the main way to oxygenate patients. If an attending asks you, if you're a learner, you should say FiO₂ and PEEP. But to really impress them, you say it's really by mean airway pressure. And the way I think about this, and this is just me thinking through things, is there's another map that's important for a body for perfusion. That's the mean arterial pressure. And we spend most of that time, when you calculate it, about 1/3 of the time is systole, which is a higher pressure, and 2/3 of the time in diastole, which is a lower pressure. And you take the average of those numbers, 2/3 and 1/3. So most of the mean arterial blood pressure comes from your diastolic blood pressure. Similar to what we're thinking about when we talk about the mean airway pressure, most of the time is in exhalation. So that's why PEEP is so important. Number one, so we don't have our alveoli collapse and get atelectasis. And you want to maintain the alveoli surface area so diffusion can occur. But to some extent, the peak inspiratory pressure or the plateau pressure, we'll get into those two terms. So let's just talk about the inspiratory pressure is also important here. And in some more sophisticated ventilator modes, we can actually keep that higher inspiratory pressure elevated for longer periods of time. We can simply give them a higher pressure or maintain that pressure for a longer period of time. That would increase the mean airway pressure. That would distend our alveoli. We still will keep the PEEP going, but that will ultimately help with diffusion by increasing the surface area and alveolar distension. Now, again, we don't want to cause volume trauma, which is injury to the lung from high volumes, or barotrauma from injury to the lung with too high of pressure. But the true answer is it's by mean airway pressure. And that's if you get into, I have an episode on APRV. That's what we're doing in APRV. We're maintaining this P high, this pressure for a long period of time, and then we drop them to a P low for a shorter period of time. So we're maintaining this high mean airway pressure. Sometimes on the ventilator, if it's not APRV, basically we can also change the I/E ratio. We can keep the inspiratory pressure elevated for a longer period of time, equal to that of the expiratory time. That's what we mean by 1-to-1 ratio. And that would increase the mean airway pressure. So really the true answer is oxygenation works by mean airway pressure. The simple answer is FiO₂ and PEEP. Since we spend majority of the patients spend most of their time in exhalation, about a 1-to-3 ratio. So PEEP and FiO₂ are the simplest way to think about it, but I really want you to know it's by mean airway pressure. And there's some more sophisticated things we can do on the ventilator, like using APRV or changing our I/E ratio to 1-to-1, which can be uncomfortable for our patients. So these are sicker patients with refractory hypoxemia, which we can manipulate the ventilator a little bit. All right, let's wrap up oxygenation there. And what's the other part? Now we're also responsible for another important thing.
Yes, we're responsible for the ventilation, the other side of the coin. Most importantly, we're trying to get rid of that CO2.
We're trying to remove CO2 from the body. As all the metabolic processes happen in the body and blood is brought back to the right side of the heart, we are getting rid of this CO2, this metabolic waste. And how I think about removal of CO2 or ventilation, if oxygenation works by diffusion, I like to think of ventilation working by something called convection, which you might remember from chemistry or physics, but basically that's mass movements of molecules from one place to another. So the way to move things from one place to another in terms of ventilation is by breathing faster, increasing the respiratory rate, or by bringing more volume in and out. So our tidal volume. So the main driver is minute ventilation, which is our respiratory rate times our tidal volume.
We see this all the time in your patients who have a metabolic acidosis. They're trying to breathe out acid, CO2, so they'll breathe a little bit faster. And then you have your COPDers who have air trapping and CO2 hypercapnia. They have an issue with ventilation.
Yeah. And Eric, I love how you brought that in too, because we're going to get to setting up the ventilator. Everyone always asks, how do you set up the ventilator? And my answer is, what are you setting up the ventilator for? What type of physiology? And as Eric mentioned, if you have someone with a metabolic acidosis, they need to blow off that CO2 because they have some kind of metabolic derangement. There's some acid in the body. They need to remove CO2. They would normally be doing that themselves. However, we put a breathing tube in now, and we are responsible for removing that CO2 or getting rid of that acid until whatever the underlying issue is causing the metabolic acidosis is corrected. So one of the ways you could do it is by increasing the respiratory rate, which is probably the most common way to get rid of CO2, by increasing the respiratory rate. As we'll see, you might say, why can't we increase the tidal volume? And you can, but depending on the situation. So we try to limit the tidal volume. We'll talk a little bit about where this comes from, but most patients, you can probably safely set up the ventilator to be about 8 mLs per kilo of ideal body weight. If you have a patient with ARDS, then you probably want to shoot in the 4 to 6 mLs per kilo of ideal body weight range. So you're going to be somewhat limited on your tidal volume because you don't want to cause volume trauma or lung injury from too high a volume. So if you set the tidal volume correctly, then the main way you're going to get rid of CO2 is by increasing the rate. But there is an exception.
In these COPDers, when we have these issues of air trap.
Or even asthmatic, anyone with obstructive disease, we can see some asthmatics, but we commonly see a COPD.
Yeah, they're going to need some more time than we would normally give a patient to get that CO2 out. So sometimes the ventilator might trigger before they've really finished their exhalation.
That's right. And this is the thing that I think gets our medical students and our residents and even some of our therapists that are maybe new. They see a very severely elevated CO2 level, and they had some basic teaching that the CO2 level is really high. I got to go up on the rate. But if you have someone with obstructive lung disease like asthma or COPD, then it actually takes a long time. Remember, they talked about I to E ratio being 1:3. Now it might be 1:4, 1:5, 1:6. So what goes in must come out of the body. So a little counterintuitive, but it makes sense if you think about it, is if you have someone with asthma, COPD with a really high CO2 level, then here you actually want to go down. That's right, I said go down on the respiratory rate to allow time for the patient to exhale, because their problem is they're not exhaling well. They take a long time to exhale. So the ventilator doesn't cure someone's COPD or asthma. In fact, it can make it worse. Your steroids, your bronchodilators, or whatever underlying therapy you're giving them will help. But in the interim, we don't want our CO2 levels going higher and higher. So if you increase the rate, you're not giving them enough time to exhale all of that CO2. So here our eyes have to look at the flow rate, which we'll put some examples in the show notes. So what comes in on the inspiratory flow must leave the body. So if I give 400 in, then that patient needs to blow that 400 out and get rid of that CO2. If you notice on the expiratory flow limb, it's not getting back to zero, and you're starting to trigger a breath, then they're trapping a volume of gas inside their thorax. That pressure will build and build and build, called auto PEEP or air trapping, until that intrathoracic pressure gets high. That will inhibit preload, and that could cause a cardiac arrest or maybe a pneumothorax in your patient. So be very cautious of that. If you have a patient with obstructive lung disease, yes, I did say that respiratory rate is what you're mainly going to use to drive out that CO2 and tidal volume. By here, we have to be very cautious. Take a listen to your patient, look at the expiratory flow limb. If they're wheezing or not moving air, and you see that expiratory limb not going back to zero, then here you'd have to go down on the respiratory rate to get that CO2 out. We've got ahead of ourselves a little bit because we're going to talk about this in setting up the ventilator for different physiologies. So we talked about already two of them, which is a severe metabolic acidosis and obstructive lung disease. So Eric, I think we should close here. I think we gave the listeners a good idea of which dials control oxygenation and how it's controlled, and which dials control ventilation, and some of the exceptions to that rule with oxygenation and the mean airway pressure and ventilation, that exception being our COPD or asthmatic.
I think that's great. We covered it pretty well, and you know what different levers you got to pull.
Absolutely. Thanks again, Rebel EM listeners, to another episode of Rebel Crit. We'll see you next time.